Welcome back everyone. In my today's lesson I will discuss about laryngomalacia. As I have discussed previously, stridor classically originates from the larynx and also sometimes from the trachea. Supraglottic obstruction is characterized by inspiratory stridor because the negative pressure generated during inspiration tends to collapse relatively soft supraglottic structures. Laryngomalacia is the most common cause of supraglottic obstruction and is the most common cause of neonatal stridor in general. And its incidence is estimated to be around 1 in 2000 children or 1 in 2000 newborn. When we see the clinical manifestation of laryngomalacia, laryngomalacia accounts for 45 to 75% of congenital laryngeal anomalies in children with stridor. Stridor is inspiratory in this case, low-pitched, and it's exacerbated by any exertion such as crying, agitation, or feeding. The stridor is caused in part by decreased laryngeal tone, leading to supraglottic collapse during inspiration. It is thought to represent a delay of maturation of the supporting structure of the larynx. Symptoms usually appear within the first 2 weeks and increase in severity up to 6 months, although gradual improvement can begin at any time. Gastroesophageal reflex disease, laryngopharyngeal reflex disease, and the neurologic disease influence the severity of the disease and thereby the clinical course. When we see the diagnosis of laryngomalacia, the diagnosis is made primarily based on the symptoms, and the diagnosis is confirmed by outpatient flexible laryngoscope. When the work of breathing is moderate to severe, airway films and chest radiographs are indicated. Laryngomalacia can contribute to feeding difficulties and dysphagia in some children because of decreased laryngeal sensation and poor sac swallow breath coordination. Because 50 to 60% of infants with laryngomalacia have synchronous airway anomalies, complete bronchoscopy is undertaken for patients with moderate to severe obstruction. Regarding treatment of laryngomalacia, there are two major types of treatment, that's medical and surgical. The first line is medical. Expectant observation is suitable for most infants because most symptoms resolve spontaneously as the child and the airway grow. In more than 90% of cases, the only treatment necessary for laryngomalacia is time. The lesion gradually improves and the noise disappears by age 2 years in virtually all infants. The noise steadily increases over the first 6 months, as I have said previously, as inspiratory airflow increases with age. Following this increase, a plateau often occurs with a subsequent gradual disappearance of the noise. In some cases, the signs and the symptoms dissipate, but the pathology may persist into childhood and adulthood. In those cases, symptoms or signs may recur with exercise or sometimes with viral infections. Laryngopharyngeal reflex is managed aggressively with anti-reflex medications such as H2 receptor antagonists and the proton pump inhibitors. Risk-benefit ratio should be assessed in each patient because those medications, particularly proton pump inhibitors, have been associated with iron deficiency anemia. Sometimes there is also increased incidence of pneumonia and gastroenteritis and Clostridium difficile infection among others. Regarding surgical management for laryngomalacia, in 50 to 20% of patients, symptoms are severe enough to cause progressive respiratory distress, cyanosis, failure to thrive, or cor pulmonale. In those patients, surgical intervention via supraglottoplasty is considered. Supraglottoplasty is 90% successful in relieving upper airway obstruction caused by laryngomalacia. Some comorbidities such as cardiac disease, neurologic disease, pulmonary disorders, or craniofacial anomalies may be a poor prognostic indicator that would suggest earlier interventions. This is what I have regarding laryngomalacia. Thank you for watching.